respected chairs, legendary panelists, and honorable members of the Bangladesh Cardiac Society, and the learned participants of the cardiologist and other faculties. Assalamu alaikum.
Selim, একটু লাউড বলো।
Cardiac rehabilitation. Sir, audible?
Yeah, audible. Audible.
I'm grateful to Bangladesh Cardiac Society Authority to give me the scope to deliver a lecture on cardiac rehabilitation, which is really underutilized and but very much important for cardiac prevention. Basically, I am just starting from the last slide of the last line of the Professor Omal Sar's lecture, where cardiac rehabilitation gives the most importance. Actually, cardiac rehabilitation is a very many subsets, but I am requested to present all over the cardiac rehabilitation. So this is the big chapters, and I try to complete the presentation within 15 to 20 minutes because it's the lunch time. So I will skip some slide and just give the flavor of the what is cardiac rehabilitation, what is the status in Bangladesh also. So secondary prevention with cardiac rehabilitation programs are now accepted as an integral component of comprehensive care of patients with cardiovascular disease. Typically, CR comprises exercise and educational programs with the aim to promote the uptake and maintenance of appropriate physical activity and healthier lifestyle change. So the goal of the CR service is to stabilize or reverse progression of atherosclerosis, reduce the risk of myocardial infarction and sudden death, control cardiac symptoms, and enhance the patient's psychosocial and vocational status, thereby positively influence the individual's recovery as well as secondary prevention. So how we define the cardiac rehabilitation? In 1993, World Health Organization gave the first define the first definition. This tells the sum of activity and interventions required to ensure the best possible physical, mental, and social conditions so that patients with chronic or post-acute cardiovascular disease may, by their own efforts, preserve or resume their proper place in society and lead an active life. From 1993, the new definition in 2021, this year, on JAC published cardiac rehabilitation for patient heart failure. They define it like this way: the physician-supervised multidisciplinary program that furnishes physician prescribed exercise, cardiac risk factor modification, psychosocial assessment, and outcome assessment by commonly accepted terminology and federal stature. So the cardiac rehabilitation history is very long. First published document was found in 1768. Was found with angina improved after chopping wood for 30 minutes a day. In the mid-1800, William Stokes advocated walking for patients with heart disease. The long time there is no history found in journal or other things. Then from 1930, it is now gradually upgrading the cardiac rehabilitation defined concept. 1930, 1940, and 1950, there is so many development. And in 1960, inpatient cardiac rehabilitation programs were first developed. And in 70, contemporary cardiac rehabilitation began. And in 1993, WHO Expert Committee on Rehabilitation first defined the cardiac rehabilitation and published a document. And the first clinical practice guideline by USA in 1995. And since then, since 2008 to 2021, gradually upgrading the documents from the different society to establish the class 1 recommendation of the cardiac rehabilitation in their guideline and in the country. So why they are doing this? What is the rationale? We know the exercise is the main components of the healthy living as well as prevention of CVD. So prevention, we know the prevention is effective. The elimination of health risk behavior would make it possible to prevent at least 80% of CVDs and even 40% cancer. So there is so many cardioproductive mechanism of physical activities. We know this. And also there is so many benefits in the heart failure, in the heart, kidneys, hemopoietic systems, liver, muscle. They are everywhere. There is the benefits of exercise and thereby heart failure. And also is reversion of pathology in heart failure. We have seen and we know the effects of the cardiac rehabilitation. So that's why it is evidence-based. There's guideline recommendation throughout the world and cost-effective and very much important in the country like our Bangladesh. So it is rational to introduce the cardiac rehabilitation in our country. So principles, I don't know, we know that because we are medical person, we know that what is in the large indications for MI to heart failure and all the congenital heart disease to other things in PCI. So there is so many indications, and also there is some contraindication. We know this one, and the most important one is phases. Worldwide cardiac rehabilitation is structured in different ways. The term phase is used to describe the varying time frames following a cardiac event. There is 4 phases in the USA and Europe, but there is some guideline. There is only 3 phases, but we are discussing our 4 phases. Phase 1, phase 2, and phase 3, phase 4. Phase 1 is inpatient rehabilitation, usually lasting for the duration of the hospitalization. This phase emphasizes a gradual, progressive approach to exercise and education program that helps the patient understand the disease process, the rehabilitation process, and the initial preventive efforts to slow the progression of disease. And the phase 2 is the multiple step physical activity to improve conditioning with continued behavior modification aimed at smoking cessation, weight loss, healthy eating, and other factors to reduce disease process. And phase 3 is mainly phase 3 is the structural supervised rehabilitation lasting for 6 to 12 months, and phase 4 is the maintenance indefinite lifestyle modification approach. So after discharge, when we starting the cardiac rehabilitation, the length of time between discharge and commencement of the phase 2 program varies between countries and facilities. The usual mode of exercise prescribed initially is walking on level ground. The intensity should be maintained between 2 and 4 minutes or a score of 11 or 12 on the rating of perceived exertion RP scale in the early stages. Patients should be told to increase their walking distance progressively to 3 to 5 millimeters daily after 4 to 6 weeks. This is so exercise precision is the most important one. I will go into details about exercise, but some characteristics of exercise is time, mode of exercise, frequency, intensity, and time. So there is also in Europe, there is expert tools to define the exercise intensity. We know this as low intensity, moderate intensity, high intensity, and very hard effort. So what is the target population? SCC-AHA classified the group in the individuals in the 4 groups according to patient's needs and patient severity of assessment. So class A, apparently health without increased severity with exercise. Class B, clinically stable heart disease, coronary heart disease, and are at low risk of CV complication with vigorous exercise. Class C, moderate or high risk of cardiac complication during exercise. And class 4, those with unstable disease. So class B and C are the more target for the cardiac rehabilitation. So before that, we have to do some exercise testing. So it is important to do an exercise testing because the absence of test may lead to an inappropriate exercise prescription. So it is usual to patient to undergo a symptom-limited exercise stress test, and this information will help us to future structural cardiac rehabilitation. So there is some exercise testing contraindication. I will not go through. We know that exercise protocols, different protocols are used according to patient needs and patient physical capacity. Commonly used is the Bruce protocol if the patient is stable, and the older is the Norton protocol. And there is also other protocol which to assess the functional capacity, like 6 minutes walk test, talk test can be used to assess the functional capacity in physically ill patients. But rehabilitation should be continued. So exercise capacity, we know that we are in resting position is a 1 MET, and if we increase the 1 MET, then it is 13 to and 15% decrease in rates of all-cause death and cardiovascular events. So this is the most important point in rehabilitation process we have to increase the patient's functional capacity. And this is the rate of perceived exertion of RPE, that is called Borg scale. In 1982, first published in 20 scale, Borg scale, but now it is modified Borg scale is 10. And exercise schedule, the preserved exercise schedule is given, especially normally 9 to 36 weeks according to patient needs, and average 12 weeks. And there are 3 steps of exercise schedule: the warm up, main exercise, and cool down. So warm up and cool down is the most important part than main exercise, because in this period patient is rehabilitate himself or herself to going to the main exercise, and during cool down, if the patient does not cool down gradually, then there is more cardiac event happen. So cool down is also important like main exercise. There is the intensity depend upon the heart rate. There are 3 methods of using the heart rate, and these include the direct method, percentage of heart rate maximum, and the heart rate reserve. So there is defined as a physical activity. We know this. There is in heart failure, there is a exercise schedule, training phase, initial, supervised maintenance, not board. And there is a exercise characteristics is given in the chronic heart failure in frequency, average 5 days per week, or moderately 3 days per week in high intensity. Like this, this schedule is depend upon the patient functional capacity and individualized. What are the components? There is actually different guideline authorities given different types of components, but basically British Association of Cardiovascular Prevention give the BSCR model is a 6 core model. The mainly health behavior change and education, lifestyle risk factor management, psychosocial health, medical risk management, long-term strategies, audit and evaluation. So these are BSCR model, and there is also in heart failure, there is another important one is the precise patient assessment is important. Is ventricular function, arrhythmic risk, because the most fatality occur in the heart failure patients. So we have to keep consider. And there is a collaborative stings and cardiac rehabilitation. There is also cardiac rehabilitation, and more than cardiac rehabilitation, there is heart failure care team. There is also patient and family, and the transition of care by the leading nurse or caregivers. So these are also important besides the other components. Not go details because. So how these components delivered in cardiac rehabilitation? By cardiac rehabilitation team, this should be consistent of dietitian, exercise specialist, nurse specialist, occupational therapist, pharmacist, physician with special interest in prevention, CPR team, physiotherapist, and always also administrative support. There is center-based delivery, and there is also non-center-based delivery. And there is CR delivery in low resource setting like in our country. If center is very much expensive, sometimes it given on the internet-based, home-based, mobile app or community-based program. And during COVID-19, the cardiac rehabilitation should not be stopped. And Canadian Cardiovascular Society in the last year, 2020, published documents regarding how the 3 steps of virtual cardiac rehabilitation delivery in COVID-19, GCR. So everybody is working as because these have the proven benefits of FCR. American Association of Cardiovascular and Pulmonary Rehabilitation give the class 1 indication of all forms of cardiovascular events, and there is strong evidence of benefit. Reduce all-cause mortality ranging from 15 to 28%, and reduce cardiac mortality from 26% to 31%, and also other so many benefits of cardiac rehabilitation. And this important one is this benefit is also related with the dose. The patient taken so many doses of the rehabilitation session get the more benefit. And there is more evidence in published in different journals in favor of the heart failure reduced ejection, and also now there is some study going on the heart failure preserved ejection fraction and other heart failure subsets. The safety is sometimes we think that it is not safe because patient may die during, but actually AHA scientific event show the complication is 1 event in 60,000 to 80,000 hours of supervised exercise. And International Journal of Heart Failure recently published in 2021 In 1980 to 1990, there is 1 in 100,000, but now, because of the development of the instruments in the center, there is a 0 to 1 case per 300,000 exercise hours, so very negligible amount of fatality. So globally, how so many benefits is being given, shown, but how global is response to CR? The global issue, every authority give the class 1 recommendation, AHA, British Association, Cardiac Society, and European Society of Cardiology. But worldwide, only 39% of countries offer CR, with a breakdown of 68% of high-income countries versus 23% of lower-income countries. In USA, despite encouraging result, outcome benefit, and cost effectiveness, CR remains underused, with participation rates ranging from 10 to 30%. In Europe, is nearly 20, in all countries, the dropout rate is high among post-MI patients, 29% dropout in 1 month. There is so many reasons of Europe to drop out. And in Canada, before COVID-19, they show that up to 75%, 80% of eligible patients are not participating. So in developed countries of the world who are practicing rehabilitation in the long time, is the result of this like this way. But why this happened? There is some barriers published in the International Journal of Heart Failure last 2021. There is the patient factors, physician factors, and service factors. So everyone is actually involved, and stakeholders are responsible for this underutilization of the cardiac rehabilitation. And adherence therapy should be increased. The most effective method for increasing the CR participation rates, automatic referral of patient with heart failure to the CR program before discharge, and nurse-led follow-up CR program can be maintained, a smartphone-based CR program, or motivation to patients and the referring physician as well. So, what was our country? Actually, very few data found regarding this, but I found one data published in the Global Heart and 2021 this year, the secondary preventive care for cardiovascular disease in Bangladesh. So it shows that the International Council for Cardiovascular Prevention Rehabilitation performed an audit of cardiac rehabilitation availability global in 2017. They found that most districts and divisions had no specialized cardiac care, as most are located in the capital Dhaka. While the available acute cardiac centers assess the main risk factors, there is a need to deliver more tobacco cessation intervention. And there is a study different heading, I not go details. They comment that despite availability of advanced cardiac care technology like PCI and CVG, cardiovascular secondary prevention is insufficiently available both in government and private hospitals in Bangladesh. This is unfortunate to have only one CPR cardiac rehabilitation structural program center in the entire country, which should be the most cost-effective life-saving intervention in Bangladesh. But this is the one center published in the journal. So how we just in the short knowledge how to implement the cardiac rehabilitation in our country. So we know that you said the comprehensive assessment and the treatment reduce morbidity and mortality, but our clinicians, healthcare leaders, and stakeholders should show attention to incorporating CR as a part of standard care of patients with heart failure and coronary disease. Although traditional CR focuses on secondary prevention, the future scope for CR should encompass aspects of primary prevention and promotion of wellness by providing intensive lifestyle management for physical, medical, and psychological support and education. So we are now at the end. So this short overview of practical knowledge, along with existing and emerging data and strategies to improve referrals, adherence, and coverage for CR provided in this presentation will be helpful in the implementation of cardiac rehabilitation in Bangladesh. And Bangladesh Cardiac Society is a registered company in Bangladesh and should advocate the stakeholders and policymakers of the Bangladesh government and other cardiologists to take necessary action to implement cardiac rehabilitation in throughout the Bangladesh to reduce the cardiovascular disease burden in Bangladesh. And this way we can reach the goal of cardiac rehabilitation together we can kill the top killer of in Bangladesh, the cardiac death. So if we can reach the goal, so our effort will be beneficial. So thank you all the audience, panelists, and the chairs for patient sharing in the lunch time. Thank you all.